Right, looks like we're recording now. Right, thank you everybody for joining us for this Outbreak Engagement Board. I think people will still probably may well be joining us as we proceed, but I think we should crack on, and we might get to enjoy the lovely afternoon sooner rather than later. Okay, so welcome everybody. I've got this right. Okay, I have to read out a very dull announcement around online meetings, which seems to get longer and longer every time we have to read these things out. So if I do that now, and then we can proceed. So I'd like to inform everyone present that this meeting will be recorded in Microsoft Teams and will then be uploaded and available for repeat viewing on the Council's website. Councillors, officers and partners attending will be asked to introduce themselves if they speak at the meeting. To help me manage the meeting, if any members of the board wish to speak, please can you indicate your wish in the chat section of your screen and then wait to be called, and this will avoid us talking over each other. When not speaking, all attendees should put their microphones on mute and switch off their cameras. When called to speak, please switch on your camera, unmute your microphone, pause for about 3 seconds to allow the slight time delay in connection. If you're addressing the meeting, it would be best if you can have your camera on so that people can see who is speaking. However, we are aware that we're at the mercy of individuals' broadband services, so it is possible that loss of connection may happen. Or if your connection is poor, you may find it improves if you turn your camera off. So we will understand if this is necessary. Thank you. So first, well, actually the second item after my welcome is apologies. I know we've got Councillor Liz Terry. I've had her apologies. Nikki, what other apologies do we have?
Yes, Chair. I've got apologies from Councillor Terry, Shona Douglas, Francis Martin, Eilish McCarthy, Deb Glassbrook, Amanda McDermott, Paul Illman, Gail Muirhead from the Fire Service, Lorraine Briffett from Connect Reading, and Dom Hardy, Nikki Lloyd and Janet Lippett from Royal Berkshire Foundation Trust.
Okay, thank you. Thank you for that, Nikki. Right, let's move on to the minutes of the last meeting. Hopefully people have been able to see them. I'm not proposing on going through them page by page, so this is now your opportunity to let me know if there's anything on there that matters that you want to raise from the minutes, or if there's anything that doesn't look like it was a correct record. I'm not getting any indications. Anybody wishes to indicate, in which case we will accept those minutes. Nick, I don't believe we have any questions from members of the public. Is that right?
That is correct, Chair. No questions from members of the public this time.
That's good. OK, so let's move straight on then to item number 5, the local COVID-19 situation update. And hopefully David Munday, our consultant public health, is ready to fire away.
Indeed.
Over to you.
Thank you, Chair. Nikki, am I sharing the slides or are you putting them on the screen? Haha, excellent, thank you. So what I'm going to do is do this, the kind of the data update bit. I'll go through it fairly swiftly because I'm using the data sets that I think we've presented at this board now a few times, but happy to take kind of any questions if anything I've said isn't clear or you wanted a bit more detail on anything. There's two parts really. There's essentially the kind of the epidemiology and the numbers side, and then there's just some data around some of the main kind of response bits of work that are happening as well. So if you move on to my first slide, thanks Nikki, which should just show us our kind of data position. Perfect, thank you. So this table you'll probably be familiar with seeing. It's easiest actually to start in the kind of the middle of those 3 coloured columns, which just shows us that the case rate in Reading sits at just under 25 per 100,000 in a week. So for context, when we had our board in February, that was at about 80, I think 85, something like that. So it has kind of come down quite a lot since February, so over the last 2 months, and back in January at the peak of wave 2, it was at about 800. What we've been seeing, I would say, for the last 4 or 5 weeks is very much a plateauing of that number. So it's come down to around the 30 mark, as I say, a few weeks ago, and it's now staying fairly constant in the kind of 20s and 30s. And then the left hand of the 3 coloured columns shows you that Reading's positivity rate is 1%. So that's of people going for a COVID-19 PCR test, the lab-based test, because of COVID symptoms. 1 out of 100 come back with a positive result, 99 come back as a negative result, which again is showing us that the prevalence is falling quite significantly. And I'll come on to the over 60s in another slide where we're showing the age. So Nikki, could we move on to the next one, please? And this is the age one, perfect. So this is what we call the age heat map. And if the numbers are a little small to see on the screen, just focus on the colours. The darker the yellow, the higher the case rate. And this is the same. It's in a week period, the cases per 100,000, but is broken down, as you can see on the vertical axis on the left, it's broken down by age group, just so we can segment the data to see what's happening across the different age bands. And what you can see is that that low rate that I've described is across all age groups. You can see that the 11 to 16-year-olds have got the slightly higher rate. It's below 100 per 100,000, which is good. Probably indicates that there is a little bit of transmission that is occurring, maybe through secondary schools, as obviously schools have reopened. However, it's a reasonably small, it's only a 5-year kind of age band, that one, so it's not actually very many cases that are within that kind of age group relative to some of the other adult age groups, 25 to 59-year-olds, for example. And probably the other thing that stands out is just how low rates are in those who are aged over 60 in Reading. And I think this is obviously really good news. We know that the more severe disease is more commonly seen in older people, and is probably an indication that the vaccination programme is having an effect locally. The fact that we're seeing such low rates in what's now a well vaccinated kind of population group. Next slide, please, Nikki. So just to show you, this shows you both the kind of trend and comparison. So the top left of these 6 graphs is Reading, and the Reading specific case rate is in blue on this graph, which runs from September to kind of current time. And then we've got England in the orange and the southeast in the grey. And you can see that, as I've described, the last few weeks of us really, I think, Chair, I'd use the phrase wibbling along the bottom in terms of how the kind of graph looks. So not really going up or down, but just some minor kind of fluctuations. And a very similar story across Berkshire, although we know that Slough's rates have remained a bit higher, and in West Berks that kind of peak was a bit lower than in other areas. Next slide, please, Nikki. And then just to show you, if you think in maps more than in graphs, and just to show you that across all of Berkshire and the Reading area, there is highlighted in the darker black outline. So everywhere across Berkshire is below that 100 per 100,000 mark, which is really positive. That's on the left, and then on the right, you can see that the only area with an increase in the last week was Wokingham, and that was actually a very small increase, while the other Berkshire areas all saw a small decline. And then if we move on to the next one, thank you. So we've talked before about the variants of concern here, and this is again just to show you that the yellow in this graph, which is data from December through to current time, was the original variant that drove wave 1 in the UK, and that is now almost completely kind of not detected. And the blue in this graph is the what was referred to as the Kent variant, which is now really the main one that circulates, albeit thankfully at much lower rates within the UK and within Reading. So if we could move to the next slide, please, Nikki. So this is showing us the mortality data for Reading, and again, this you will have seen this graph before. So this is data since the pandemic began, so in March of last year, and the orange is death was not directly related to COVID, and the blue is where COVID is on the death certificate. And what you'll see if you look, and apologies, it's a bit small, but if you look very closely, there has been in March, we had the first couple of weeks where there was no COVID death in Reading at all, which was the first time that had occurred since the summer and early September. And there is what we're seeing is in some weeks is 1 or 2 cases of COVID death. Clearly, we want it to be 0 every week, but is a good indication that we're moving through that kind of that greatest impact of the pandemic, and we now sit below the the usual death rate for this time of year, and what we need to keep an eye on is our excess mortality, because that gives us the best overall picture of how COVID has impacted our local community. So next slide, Nikki, please. So those were that's the kind of state of play. The next 4 or 5 slides are just about some of the bits of response work that are happening and and just giving you a feel for those. So this slide, there's more data on here than we need, so I'm just going to give you the headlines from it. This is our contact tracing service, and just to kind of summarize how it's working. So if you start with the red boxes in the middle at the top of the slide. So over I think it's a 6-week period, there have been, of all the cases that have tested positive in Reading, 238, so almost 78%, responded within 24 hours to the national test and trace programme to acknowledge that they were positive, they tested positive, and to receive the self-isolation advice, and then to find out who their close contacts were that would also need to isolate. Of the remaining just under a quarter, so the remaining 23.1%, they're then passed, if they're don't respond within 24 hours, they're passed to the Reading local contact tracing team. And of that quarter or so, you can see that then the Reading service contacts well over half of them. They contact 61.5%. They're successful in getting through to ensure that, again, that isolation advice is given and that we identify who the contacts are. And those numbers are shown on the purple boxes. And then, sorry, if you jump your eye to the left, you'll see then the black box, which combines that shows us that 9 out of every 10 people in Reading who test positive are contacted either by national or by the local service and get that isolation advice, and the contact identification is done as well. The next slide then, please, Nikki. This just shows us about the isolation support that we're now offering. So over the last 2 weeks, we've started contacting everyone who tests positive in Reading, regardless of whether they've already responded to the national contact tracing offer or they're someone that has been picked up through the local. But we contact all of them a few days later to kind of reissue, if you like, some of that the advice in terms of the importance of isolating, but then also try to identify where there's any support needs that they may have, which might cause isolation, might prove it difficult for them to isolate. So that would include access to the isolation support payment. That would be access to services around the One Reading Community Hub, access to the NHS volunteers for things like prescription collections, etc. So you can see that actually the majority of people aren't needing one of those services, but it's offered for those and available for those who do. And as I say, that isolation a kind of requirement is reiterated at that contact. The next slide then moves us on to talk about vaccination, which I know is a topic of interest currently. So the data here is just showing us, if you look at the blue graphs, it's breaking down in 5-year age bands, what the uptake of the vaccine is in Reading. So this ranges from 76% in our 50 to 54-year-olds up to 92% in our over 80-year-olds. And then both the yellow line across the top, but then also if you want the actual numbers in the table at the bottom, just compare Reading to the England average. And you can see that we're between 3 and 6 percentage points below the England average. Some of that will be because of the data cleansing issues with residents who may appear on the system to be kind of within Reading still, but have moved out, and that affects Reading a bit because of a reasonably mobile population. So it may be that the rate is not, the difference is actually a little smaller than that, and it's partly because of some hesitancy in coming forward with vaccination in some parts of Reading. However, when we compare this to the flu programme, we're seeing an uptake rate of about 20%, maybe more, higher than we see with the flu programme, and any differences are kind of less marked as well. So undoubtedly, it's it was still in rollout, isn't it? But is a success. It's been a successful vaccination program, and there is a bit of variation in terms of different parts of town. So uptake isn't uniform across Reading, and we see probably something like a 15% difference between different parts of town, or between different ethnic groups in terms of that variation in uptake. And I'm sure, as people are aware, the current offer for vaccination is now dropped down to those aged 45 and over, and then we're awaiting details of when it goes down to those aged 40 and over, and it continues through the age groups. So if we go to the next slide, Nikki, it just summarises some of the action that's been taken locally to address where there is that difference, either Reading a bit below the national average or differences across the borough. So there's been a very popular video by one of the lead nurses at the Royal Berks, Bernice, who's Kenyan, and that's received a lot of positive feedback and has been a helpful kind of medium of communicating the vaccination message. I won't read through everything on the slide here, but you can see some of the engagement that's happened. And most recently, pop-up clinics, one at a mosque and then one at a church in Whitley, to ensure that the offer is as accessible and as straightforward for people, particularly where there are any areas of slightly lower uptake. We know currently we're in the month of Ramadan, and there's a communication toolkit that's been put together for that, because there's the question for those who are observing Ramadan about whether they can or can't have their vaccine during that time, or whether it should be after daylight hours, etc. So that's all been put together in that communication package. And then the last one on vaccination is then just to try and pick up the question about blood clots, which again has been in the media quite a lot recently. And this is hopefully a helpful slide that's been put together to quantify what the benefit of the vaccine is, and then what the risk of vaccination with the AstraZeneca vaccine is. And these clots that are reported are incredibly rare. It's the kind of 1 in a million type event that someone would die from one of these very unusual types of clot, but not something that can just be ignored. So on the left of this graph in the blue, you can see the benefit of the vaccination in terms of preventing intensive care admission. And on the right, the potential harm from the vaccine. And the reason, therefore, that those aged under 30 are being offered, if they're a carer, or if a long-term condition currently, or will be if they're, when we get to all under 30-year-olds, will be offered an alternative vaccine, is because the benefit versus harm kind of ratio is essentially the same when you look at that data. However, as we move to those kind of younger age groups, of course, what this graph doesn't show us is the other benefits of having the vaccine, which include increasingly strong data that the vaccine reduces transmission from person to person. It doesn't simply reduce your risk of being hospitalized or being in intensive care. It also makes it less likely you'll pass it on to others. And we also know that it will reduce the chance that you develop long COVID if you maybe don't have hospital admission, but you could suffer the effects of COVID infection for some time. So I think the message continues that it's highly important for all of that kind of adult population. And then the last thing from me, I think, Nikki, if you flip forward, please, is the yes, actually we can skip that one and just go to the final one if that's okay. It's just to show where we are at with the lockdown release. I'm sure people are familiar with this now, but the next milestone is no earlier than the 17th of May, and we'd expect an announcement a week before that about moving to step 3, and that will be where we see some of the indoor hospitality reopen, as well as the rule of 6 moving to be permitted indoors, and with larger numbers gathering outdoors. And it may be less relevant now for the football club, but some return to kind of live sporting events as well, but maybe not the playoffs at the Medeski, sadly. And then obviously step 4 is 21st of June or later, depending on government announcement, where again a much further kind of relaxation. So that's everything from me. Kind of deliberately gone through that at pace, but I hope that's helpful. But happy to pick up any questions.
Okay, yeah, thanks, David. Yeah, any questions? I was going to ask you or point out that the risk correlation, which doesn't include long COVID and the real serious, considerable health effects from that, isn't really a very good comparison. You made the point yourself. Any questions? Anybody or points anybody wants to raise? I haven't had any indications yet, but this is your moment. No, I've not had anyone. So thank you very much for. Oh, hang on, Andy Cichersky, you got your hand up.
Yes, hello, Chair. Andy Cichersky, GP and Vice Chair of the Health and Wellbeing Board. David, just out of interest, to know, do you have data on how much of our population has been going to the mass vaccination site versus going to the local vaccination sites? I think it's important that everyone gets vaccinated. It's not a competition, but it's just to understand where people's preference has been as to where they've been going. Do you know what the figures might be?
Yeah, it's a really good question, and you're right. We want to make sure the vaccine's as available, as convenient for people, whether it's at the primary care site. I know that increasingly there'll be pharmacies in Reading that will be able to offer it, and then obviously the Medeski for the mass site. I haven't got that breakdown to hand. I'm sure it exists somewhere, but so we'll look for it. But I think the overall message is that I think people in Reading do seem to be engaging, and hopefully we've got those options about right in terms of where people can go to ensure it's easy access.
Thank you.
Thanks for that, David. And I got a question from Tevye, actually, from our local government reporter. It was a good question, though. How many pharmacies are now offering the vaccine in Reading?
So at this point, there's one pharmacy and 2 which are virtually, if they're not now, so let me restart. One that's definitely been running for a while, and that's the Triangle Pharmacy in Tilehurst. There are 2 further, which I think are, if they're not yet live, are about to go live. So that's on Early Road and also at Western Elms. Okay. And just to clarify then, in terms of access to pharmacies as a route in for vaccination, that's through what's called the national booking system. So people, when they become eligible primarily because of their age cohort, do receive a letter inviting them to come forward for vaccination. And for most people, they use the website, will book in, and it gives you a list of options. So it will give you the Medeski Stadium. It will give you other mass vac sites if maybe because of work or whatever else, it's more convenient to go to Basingstoke or go to Oxford or whatever, and then it will also list what the pharmacy offer is locally as well, and then you simply book where's most convenient.
Great, thank you for that. I haven't got anyone else indicating. I suppose it's probably worth saying that you obviously did address it within your presentation. One of the areas that will be really important will be that variation in take up amongst communities and geographies, and I guess that's something for us over the next month or so, is further investigating that data and thinking about how we support. I mean, obviously it's an NHS programme, but how we support public health in terms of encouraging and driving up take up where it might be lower. Okay, I don't got anyone else indicating, in which case we've got Nikki Barton and James Crosby, a sort of double header, communications and engagement update.
Right, I'm starting. If you can go to the first slide, Nikki. So every time I just like to give a quick recap of what our strategic approach is in terms of communications. And we've got 3 sort of lines of attack that we take. So the first is that we work with the national messages, so from the NHS, Public Health England, government resources, or whatever so it could be the DFE, whatever the campaign is or the key messages at the time, we're amplifying the national messages. We're responding to whatever our local issues are, so whether we have new test sites, whether there's a particular local outbreak, whatever might be going on locally. And then we're also trying to target and create specific communications that meet local needs. So that could be a language need, it could be a particular question that's come out of a certain community, it could be a particular time of year or a religious festival or whatever, which requires specific targeted messaging. So that's our strategic approach. Next slide. And the tools that we have and our current focus. So we're thinking about who we're talking to, audiences, what are we saying, and what are our channels. When we think about our audiences, often these people are the same people, they're just sometimes in different groups. So you can be a younger person and you can be a parent, or you could be younger and you could be a student, or you could be a younger person and you could come from a particular ethnic group. But the kind of things we're thinking about when we're targeting communication are whether someone lives in Reading or works in Reading or both, whether they're younger or older, what their background is, where they live, what their employment status is. All of these things might mean they need different information. The particular phase that we're in now, thinking about coming out of lockdown, coming into sort of phase 2, phase 3 as we lift lockdown. So clearly there's government guidance that we need to explain to people so that people are clear what they're allowed to do, and also the reasons behind it. So it can be a bit tricky to remember whether it's 6 people outdoors or 2 family bubbles or whatever, but reinforcing those messages about why those things are in place, because of where it's easier to transmit the virus and where the particles get blown away and all of that kind of thing. Vaccination and tackling vaccination hesitancy, testing, and this is particularly about normalising the idea of testing twice a week. And I think we've seen over the past year that some things that people thought might not become normalised or weren't going to, would never catch on, are now quite normal. So keeping a 2-metre distance when you're queuing, and particularly wearing a mask, these are much more normalised now. So we're hoping that we'll get to a stage where testing twice a week is more normalised, and that's one of the things we're focusing on, letting people know how they can access testing. Self-isolating, this continuing insight from SAGE and from local insight and from many sources, which says that many people either don't isolate when they should, or simply don't understand or don't know when they should isolate. So sometimes it's sort of a conscious decision that it's not going to work for them, and sometimes it's an unconscious mistake because they've not understood how it works. So we've had a real focus on letting people know when they should self-isolate, but also what that means and what support might be available for them if they're self-isolating. And then also we've got quite a lot of special events at this time of year, lots of bank holidays, local elections, Easter, Ramadan, Eid, there's lots of events going on. And then just a reminder of how we reach people. So we work with the local media, we have the council site, so we have our own social media channels and our own website. We have our residents email, which currently goes to our full database of 100,000 people each week or each fortnight. We're using our physical spaces, so where we've got fences and barriers in parks and the town centre, where there are digital billboards, things like that, we're using all of those spaces. And we also work with our partners to get messages out. That could be sending newsletters, it could be providing the specific materials that we've produced for them to use with their audiences and channels, or it might be that they make a request of us. So at the moment we're working with local schools who've got some requests for banners to go on the perimeter fences around schools about social distancing during drop-off pickups. So we're working with partners as well. Next slide, please. So just every time I just like to give you a few examples when I talk theoretically about it, about the kind of stuff we've put out, examples from different channels, what those messages are. So these are some examples of how we've explained the roadmap. So talking to people about the different dates, the changes to the rules that are coming, what the new activities are that people are able to take part in, what they can and can't do, and again, the reasons why. So there's a bit here about council facilities reopening and accessing sports, but there's also reminders of the importance of meeting outdoors and keeping space. One that I hadn't mentioned before as well, you'll see there, is at the end of shielding as well, is another one of these kind of guideline changes which we've talked about. Next, please. Testing. So these are some examples of how we talk to people about testing. The centre panel is from our residents' email. So this is, giving people the sort of long form information about all the different ways they can access testing, whether it's community testing sites, ordering at home, picking up from pharmacies, getting it via schools, getting it via their own employer. On the left, you can see a video we made with Nisa, who's our community outreach officer. So this was a video that we both put out publicly, but also that Nisa can use with the it's an example of the partnership and relationship communications that we do. So Nisa uses this directly with her partners to that they can push it out. It's made as a low-res YouTube video, so it can go out through WhatsApp groups or other forms that those communities might have. And then on the right, there's just an example of some of our social media and paid digital communications. Next. Same again with the vaccine. So in the middle is Bernice. This is a film we made with the nurse at the RBH. David's already mentioned this. This was incredibly popular, so we also put it into a paid campaign. So it was very popular when we used it on social media, so we put a bit of money behind it to try and get great reach. And examples of the kind of messages we've got going around vaccines. So some of the messages are simply how to access it, so it's quite simple facts. Some of it is what we call social proof or social norming, so we put out communications about how many people have had it and are you one of them, and get the facts. So there's a bit of kind of reassuring people, safety in numbers. And then there's some specific things. So on the left, you can see the connection between vaccination and Ramadan, and the fact that the Muslim Council and others are saying that it's okay to take the vaccine and to be tested during your fast. Next. I mentioned also self-isolation and support payments. So we had, you can see there one of our ad vans. We had some targeted communications on mobile vans and bikes in wards in Reading where we knew that infection rates were perhaps a bit higher. And our focus there was again on when you should self-isolate, but we included support mechanisms, so where you can get wellbeing information and how to access a self-isolation payment. There's a case study there of someone who self-isolated and explained why he thought it was important. So again, some social norming and some stuff on the wall. So what it means, some of the insight we've had is that people don't always fully understand that self-isolating means not even going to the shops, or not even going for exercise, or not even dropping the kids at school. So reinforcing what it means. Next. Some examples of how we've used signage in our parks and open spaces. We've had residents, get involved in our photo campaign about do the right thing, and we've had a focus on hand washing and staying apart and fresh air and ventilation and blowing particles away, but also wash your hands when you get home. Don't take the virus back to your home. I think the next one, I think that's the last one, or the next one's the last one. And the other thing is these special events. So I mentioned already Easter, bank holidays, Eid, Ramadan. We've got lots of events, and of course also there was the death of the Duke of Edinburgh, and there were funeral arrangements and mourning arrangements at Windsor, and also some activities at Reading. So just adapting all of those communications to be advising people how to stay COVID secure. So those are just, it's a run through just to give you a flavour of the different messages and the types of channels and communications that we've been using to reach people with those kind of different key priorities. And that's all, I think it's over to James now. That's all from communications.
Thanks.
Thanks, Nikki. So I'm James Crosby. I'm the Interim Assistant Director for Planning, Transport and Regulatory Services. As part of the work that our teams do, we've been working with businesses across the town, looking specifically at higher risk settings. And these are sort of typically businesses where there's a high footfall, lots of people coming into close contact, and during the earlier parts of the easing of lockdown, we had things like close contact settings, for example, hairdressers or nail bars as some of the businesses that we were working with. And we've been going out and doing inspections of those businesses, providing advice. And some of you may have seen I think there was a piece on Meridian a couple of nights ago, where one of our officers was going into some businesses on the Oxford Road and providing advice and support to those business owners to try and ensure they understood all of the current rules, because clearly there's been quite a lot of change as we've gone through the year on those. We work really closely with the Town Centre Business Improvement District to provide support to those businesses, and where necessary, get involved in looking at compliance. And when we had the reopening the other week, we had officers supporting the town centre marshals to ensure that the shops had the right measures in place, that queuing was working fine, and that the flows into the businesses were all safe and compliant. We've also been working with Pubwatch and the wider hospitality industry to provide them with guidance and support as they start to open up. And a lot of the town centre businesses, for example, they perhaps aren't able to open yet because they haven't got the right outdoor space. But where we can, and we've been trying to help and enable that to happen. We've also been working with businesses across the town, and there's been quite a few sheds pop up here, there, and everywhere to try and accommodate people during the colder months now. And officers have been going out to them and providing advice, because quite a lot of them actually are quite enclosed. So not only sort of dealing with the COVID risks, but also there's other regulations, for example, around smoking. So we just need to make sure that there's as much compliance as possible with those businesses. We do quite a lot of work, and actually weekly work with Thames Valley Police to look at the national test and trace data, areas of positivity across the town, and then where there are reports of non-compliance to the police around gatherings or business breaches. And we then collectively map that information and use that as a mechanism to target resource. So, for example, each week I will provide a list of areas for the police to go into and just provide some additional reassurance or some resource to go in and speak to businesses or individuals who are gathering on the streets, for example. And that's been really effective, not only for those areas, and what we've sort of seen is where we put that resource in week on week, the positivity does seem to be coming down. But also, I think it gives the police some reassurance that they're actually doing something with the resource that they're putting on, because I think it's often difficult for them to see, what the outcomes of their work are. And when you see that with the national test and trace data and that level of positivity dropping, you get a really good feeling about that. We do a lot of work around investigating complaints in businesses, and we get a lot of sort of email traffic predominantly around particular businesses where people are unsure if they're being compliant, and we will always follow that through and investigate those inquiries, just to make sure that people understand what the requirements are, or to go back to the customer and say, actually, that's unfortunately, that's no longer a requirement because the rules have changed again. And again, the sort of final point here, we work with public health colleagues to investigate outbreaks and follow up, particularly where Public Health England have been unable to get some of the local context and data from businesses or individuals. So, for example, in the last few weeks, we've had some cases where there's been a positive case in a house of multiple occupation, and the individual in that house of multiple occupation hasn't been able to say who they live with, the names, the details of the individuals they live with. So our teams go out and they follow that up, and they get that information to ensure it goes into the national test and trace data and ensure that those individuals are self-isolating. So that sort of all of that information that comes into the authority is always picked up and followed through, and it's really useful for us to help control that positivity rate. Next slide, please, Nikki. So just one quick example, really, of one of the outbreaks we've investigated recently, and this was some information received directly from Public Health England, where there was a business with 8 of the 15 staff who tested positive. They knew that all of the positive cases were isolating because they'd done that follow-up and discussion with those individuals, and Public Health England have been able to show that some of the information from the management team at the store was okay, but actually they needed that on the ground view, because it's really difficult to understand quite what somebody's talking about over the phone without seeing the layout of the store, for example. So one of our environmental health officers contacted the store and the regional management team, and they spoke to them about each of the individuals, and they did some backwards contact tracing to find out perhaps where the index case was, and again, just making sure that they were self-isolating and that they did understand the position that they needed to take on that. They reviewed their risk assessments, and they went through their social distancing procedures. They looked at the store capacity, and in fact, actually, in this particular store, they would normally have 40 staff working, but because of COVID, they'd furloughed quite a lot of their staff, so they only had a small cohort still working. But they also look at, in this particular store, they use staff temperature checks as part of their COVID risk assessment, and things like staggered break times to ensure that there weren't that many staff mixing at any one time. The store also arranged for a deep clean of the store prior to reopening, again, just to make sure that all of the contact points were sanitized. And in terms of our involvement, what we were able to determine was that the face-to-face contact, so things like the management team conducting one-to-one staff meetings, the way in which the staff rooms were used, they weren't huge, and even though the break times have been staggered, there was still probably too many people going into quite a small room. So the store actually changed the way in which they operated their break rooms and used a meeting room to actually increase the capacity so that they've got a bit more space. And the other thing that they hadn't done, which was a bit of a surprise really, given the sort of promotion of this, was that they weren't routinely using the rapid lateral flow tests. So obviously the council promotes heavily the use of the community testing sites, and equally the Department of Health and Social Care have promoted businesses taking up their own testing in stores, and they hadn't been doing that routinely, so they're now doing that as part of their reopening procedures. Thank you, Chair.
Great, thank you. Do we want to take a break? Any questions, any points anyone wants to raise? I mean, the only one thing I would ask, and I think I know that this is something that's being very much considered, is in terms of the engagement with particularly with the moving towards indoor hospitality and stuff, about the messaging around ventilation and the need to sort of maintain distance and the risks around aerosol transmission. Is that something that's certainly covered in that engagement?
Absolutely, yeah. I mean, it's. I think what's been happening is the industries have been, particularly in hospitality, have been looking at those options. I mean, I know on I'm trying to remember which lockdown it was, lockdown 2, and some of the pubs were reopening. We're even getting to the point where we were saying to some of the older pubs that had sealed their windows shut with paint to break those windows open again, and just to ensure that there was adequate ventilation in those businesses. But a lot of those businesses have started to look at new ways to provide better ventilation in those spaces, because some of those businesses are quite large, and the through flow of air is not great in them. So officers have been advising on each of those cases as they go out.
Okay, thank you. I haven't got anyone else indicating, so in which case we'll move on to the universal testing, and it's welcome Gabby Hafner. Now, sorry, someone did send me an email with your job title, but I can't quite find it right now, so maybe introduce yourself.
That's quite all right. Hello, I'm Gabby Hafner. I'm a health protection specialist with the Berkshire Public Health Hub, and I'm just going to take us through universal testing. So if I may have the next slide, please, Nikki. So I thought we'd just start with a quick recap about the types of testing that are available. Both PCR and lateral flow tests involve swabbing tonsils and the nose. And the PCR test, that's the gold standard test, and outside of healthcare, it tends to be used for those who do have symptoms of COVID-19. It has to be sent to a lab. It takes a couple of days to get the result back. The lateral flow test is a much quicker test. You don't need a lab. It works a bit like a home pregnancy test kit. It isn't as accurate as a PCR test, and it's currently used for people who don't have any symptoms. May I have the next slide, please? So at the beginning of this month, the government announced the universal testing offer, and that is where they are asking, saying that everyone in England is now able to access a test at a site, to collect a self-test kit, or to take home or order a test kit directly to their home. And they removed this specific eligibility criteria to make it easier for people to understand and access testing. There are a few schemes where specific testing regimes are required, such as international travel and people working in care homes and in the healthcare sector. What they want to do is use this testing to get people into the rhythm of testing, and the recommendation is that everyone test twice a week. Currently, where your lateral flow result is positive, you do need a PCR test to confirm your result, and that's particularly important at the moment where the outlying prevalence is quite low. It also allows that the test results can be genomically sequenced to look for variants of concern, which you can't do with a lateral flow result. Now, the next slide, please. So the home test kits can be picked up from a variety of places, and Nikki Barton outlined some of those in her comms section. So some employers have signed up to a scheme where they're either conducting testing on site or they're providing test kits at the workplace. A number of pharmacies have signed up to it, including 28 in Reading, and you can find out about those on the NHS Test Finder website, if I can get my letters in the right order. You can also pick up COVID testing kits at COVID-19 testing sites, such as the PCR sites at Prospect Park and London Road near the university. And looking at the first 2 weeks in April, each of those two sites was giving out over 650 test kits a day, so quite a few. School children and staff are being provided with kits via schools, and there's quite a, basically, also you can order kits online, and colleagues tell me that those kits arrive sort of 24 hours later. So basically test kits are widely available. One of the issues we have is people are collecting the kits. We can't be certain because of the data at the moment how many people are using them. And what is particularly important is we do need to encourage people to upload their results, even if they're negative. May I have the next slide, please? So the benefits of testing, really. So it's important that we try and get people into the rhythm of testing, and there are plenty of people in the community who have COVID without any symptoms at all, particularly people who are younger, and only by identifying some of those cases and getting them and their contacts to isolate can we help reduce the numbers, particularly in areas where there's stubborn enduring transmission. And if I can move on to the next slide, please. And then just talk a little bit about variants of concern. So David mentioned earlier about the Kent variant. So variants of concern are where the virus has mutated, and because it's basically just trying to survive and continue to infect as many people as possible. The Kent variant that David mentioned earlier is now the dominant one in England. And while it is more transmissible than the original virus, we do know that our vaccine is effective against it. You may be aware of the South African variant, which is currently 44 cases in some of the South London boroughs where they're undertaking surge testing. This one is of more concern because we don't fully understand how effective our vaccine is against this. And then more recently, you may have heard that India is suffering a significant second wave at the moment, partly due to another new variant thought to have started in Mumbai. This may affect younger people and has contributed to India being added to the red list for travel in the last few days. And that's it from me. Thank you, Chair.
Great, thank you. Thank you for bringing that. Any questions? I know sometimes we've sort of gone through, but any questions, any points anyone wants to raise on that? I will ask something. It might be worth just expanding out. So I think often doesn't seem that there's any point to people if they have a negative lateral flow test at home about reporting that result, and if you wanted to sort of expand why that's important.
Yes, that's a really good question. So if you don't report your negative test results, then the sort of overall stats are rather skewed towards a positive, and it looks like there's more positive cases out of the total number tested than there actually are. If we get more information, we also want to get people in the habit of uploading those negative results. And there's currently a number of pilots about to start for mass gathering events, such as concerts. And we need people to get in the habit of testing and uploading their results, because it may well be to access some of these events in the future, the testing will be more significant.
Great, thank you. Well, I don't see anybody else indicating, in which case, thank you very much, Gabby, for coming along and presenting that. We've now got the local outbreak control plan. We're sort of jumping across, are we, from, well, the lessons learned. Item 7, lessons learned, of course, was very swift. It was a swift segue, wasn't it? James Crosby actually included that in his report. So, and we've done universal COVID testing and now the local outbreak control plan. We're whizzing through this. David.
Great, thank you. Yeah, so it's back to me for this one, Chair. So just wanted to update the board on where things are at with our local outbreak control plan. So people may remember that I think it was a request in early May came through centrally from national government for local authorities to write outbreak control plans to ensure that we had the plans and processes in place to sufficiently control COVID locally. So we developed one in Reading, and by the end of June had that work largely complete, and published the summary slides on the council website, and I've included the URL there if people are interested in looking at that. There's then the more kind of detailed plan that goes through kind of in quite a lot of forensic detail, different kind of processes and escalations and communication channels, etc., that kind of sits behind that higher level summary. Clearly, since the summer then, there's been a whole new wave of the pandemic, a new variant that we've been referring to earlier. The response work has evolved as well. And off the back of that, all local authorities were asked to provide updates to their control plans earlier in March, which we've undertaken, and just wanted to give a bit of a feel for that. So next slide, please, Nikki. So this is, you're not supposed to be able to see this, but this is just to show you kind of what was in that initial plan that we had put together. So this is just a screenshot of those summary slides, and we try and kind of go through a little bit about what the impact and what the features of Reading are, specifically how we manage the risks that COVID poses us, and the different ways of managing an outbreak, along with the kind of partnership and kind of governance processes. So that's kind of the plan as was, and it's not changed dramatically. Nikki, if you go to the next one for me, and that initial plan, we were asked to include these 8 themes within it, all of which were kind of important parts of how we've sought to control the pandemic here locally, and so each of the slides, if people look at it, you'll see kind of the detail against those 8 headings. If you go to the next one then, please, Nikki, the main bit I just wanted to highlight then was just to show you that we've updated some of those themes a bit now. So a couple of the themes have been combined into one. We've added in a couple of new themes. So just wanted to highlight the areas which probably would be most different to what was initially put together. So I'm just going to touch on those 3 areas. So that we've kind of highlighted in bolder font on this slide. So the second of the themes being about testing and responding to variants of concern, and we've kind of touched on this a little bit already, and people will have heard about surge testing, sometimes referred to as Operation Eagle, and where there's local areas where that testing's been undertaken, and essentially the kind of the driver for that is where a variant of concern is identified, and it doesn't appear to have been acquired abroad and isn't kind of related to overseas travel, but seems to have been acquired within the community from someone else who was infected and unknowingly transmitted the virus. So that's where that kind of surge testing is potentially used to try and kind of identify that as rapidly as possible and isolate off that variant so that it doesn't start to spread further. And sometimes that just means testing of the contacts of a case as opposed to them simply isolating. Sometimes it means testing in a little slightly wider ring of people, so it might include those that wouldn't quite normally meet the case definition of a contact, but maybe work colleagues in the 7 days before the index case was diagnosed. And then sometimes, and what's maybe been covered in the media more, is then where that's been a whole community that have been asked to kind of come forward for testing. So we've developed a plan in Reading about how we would rapidly deploy surge testing should it be required. We've not been required to do that to date. But we just obviously don't know if or when a variant that needed that level of testing could crop up. So we've got plans in place about how we could deploy council staff, how we could work with partners to try and mobilise people to do to kind of help get that testing kind of undertaken. That would include, for example, deploying the mobile testing unit vans to specific sites where that testing was needed. It would include the potential for door knocking, even for for distributing by hand or through the letterbox, kind of home these home PCR test kits, and then collecting them back again. So that's the main thing around the testing and variants of concern to highlight as a new area within our control plan. On vaccination, then, I just wanted to highlight. I mean, I've spoken about vaccination already, and had a bit of a discussion about how it's working locally. Clearly, and as you alluded to quite rightly, Chair, I think the work in the coming months is about ensuring that equality of access, and that all communities in Reading have good access to the vaccination, good uptake rates. People aren't being left behind as we kind of roll the programme out. So that's kind of one part of it. And then the other part of it is about the potential for the need for boosters with the vaccine, if we think into the kind of medium term, either to prolong the kind of longevity of immunity levels, or to provide the protection against variants where they may kind of make a vaccine slightly less effective. And that's something, for example, with the flu programme we do every year, where we use a flu vaccine which is specific to the kind of most common or the latest strain of the flu virus. So, and it may be actually that those two programmes do end up combining, and we very much have a winter flu and COVID programme in terms of vaccination. So that's thinking a bit more into the kind of medium term, but one that will need to become part of business as usual in terms of how we deliver services for local residents here. And then the final kind of additional one, I suppose, is about enduring transmission. And that's not so much about where you get a short, sharp outbreak, a little bit like the premises that James referred to just earlier in the lessons learned bit. But where there are particular bits of town, communities, segment of Reading where transmission just seems to kind of be ongoing still. We're not really seeing that at this point, I'm really pleased to say, but the kind of actions that sit under this are about being able to kind of escalate and de-escalate some of our kind of targeted communication activity, and Nikki's touched on doing targeted comms earlier, or indeed ensuring that testing is even more accessible in those particular areas or with those particular community groups. It's a bit about ensuring that our data surveillance systems picks up any of that as early as possible. I've not presented all of the data by any means that we have access to now, but we do get case rate data down to what we call a lower super output area, so a real kind of quite a tight neighbourhood level. So we can identify where there may be areas where there's kind of stubbornly higher rates. We're also within this is then the enhanced contact tracing, and James just referred to kind of reverse contact tracing in what he said. And just to explain about that, whereas we're used to doing contact tracing to think about, well, when someone is tested positive, where have they been and who have they interacted with in the last 48 hours, or the 48 hours before they had symptoms, and at any point until they got their test result and found out they were positive, who could be a contact they could have inadvertently passed it on to. So that's the standard contact tracing. This enhanced contact tracing or reverse contact tracing is where you look back further still, and you go back at least 7 days from the date of the test, and you try and look at, well, where did that index case, as they get referred to, potentially acquire the virus from? So we now get kind of data that comes through that will show us where what we call common exposures occur, i.e. where more than one index case has said that they have been in that 7-day period where at some point they must have acquired the virus. So that could be a shop, a supermarket, it could be a place of work, it could be a recreational site, it could be a range of places. And where places start flagging regularly is an indication that there may be transmission occurring. So that then helps kind of focus kind of energy and attention. And then the final thing around the enduring transmission piece is just about ensuring that any of the support services, so via the community hub and those kind of associated services, are accessible. And again, that can be kind of stood up and stood down. So those are the bits that are probably more different that have kind of evolved in the plan. And what we'll do, it's not yet there, but what we will do is provide that same summary that we did initially with the updates, so that's on the website, kind of in the same place, but with the newer kind of evolution, if you like, there. So I think that's all I wanted to say on the plan itself. But again, Chair, happy to take any comments or questions.
Great, thanks, David. Yeah, any comments, questions, points anybody wants to raise on that? Okay, I'm not seeing anything, in which case, thank you, David. I think we touched on a lot of the things that's sort of within that in the previous item. So
yeah, indeed.
Okay, thank you. In which case, and see anyone indicate just the last item of the agenda is the date of the next meeting. We have a suggestion, and if anybody got sort of early at the beginning of the meeting, there's a little bit of a discussion about whether this Outbreak Engagement Board should continue as a separate item, or whether perhaps we should think about including the issues here within the Health and Wellbeing Board. I mean, I think at the moment it's far too early to know exactly where we'll be in the coming months. So we have a proposed date, don't we, Nikki? Which is early July, and I can't quite remember the exact.
July, Friday the 2nd of July.
Sorry, Nick, I didn't quite catch that.
Sorry, I didn't put my thingy down on the headset. Friday the 2nd of July is a suggestion.
Okay, thank you. I've got Andy Chichesky. Thank you. I've got Andy Chichesky indicating.
Just a thought, Chair. I mean, as we've got our Health and Wellbeing Board, I think a week or two into July, Nikki can confirm the dates. Unless something dramatic happens, do we want to cancel that proposed date nearer the time and incorporate it into the Health and Wellbeing Board, or do people prefer to keep it as a completely separate meeting? I'd have thought that the way things are going at the moment, if we stay positive about how things are going, we could just incorporate it into as a quick item. We've been quite quick today because there's actually just been updates, isn't it? So if things keep going the right direction, there won't be much to update next time, hopefully. I'm always optimistic, you know I am.
No, always, Andy. I've known times when you're not, but no, that's certainly my thinking, and I guess we don't exactly know where we'll be if things carry on the current trajectory. Having a separate meeting would probably feel like overkill. If there's something goes wrong in terms of variance, we find ourselves in a different situation, then that's something we might want to address in a separate meeting. So we'll have that as the date of the next meeting. But as I say, if we'll have conversations over time, and if things are looking good in the coming months, as we all wish and hope they will, then maybe we could cancel that meeting and roll those issues into the Health and Wellbeing Board. Hopefully that makes sense to everyone, and I don't hear anybody else indicating or suggesting that's not a good idea, in which case, thank you everyone for coming to this meeting. It's really one of the swiftest meetings that I've ever chaired, and I'm sure that's about the excellent presentations we've had rather than my chairing. So unless anyone's got anything to add, thank you everyone. Enjoy the rest of the lovely day, and hopefully everyone has a great weekend. Thank you.
Thank you, Chair.
Thank you, everybody.